Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. I want to welcome back my two co-hosts, Dr. Daniel Lenahan and Dr. Arjun Ghosh. It's been a minute since we have been together, but welcome back, Dan. How are you?
Super. Thank you.
And Arjun, good to see you again. We just spent a little bit of time together at the ESC meeting in London. So thank you for your hospitality there and welcome.
Yeah, thanks. Great to be here as always.
And today it's a real pleasure for us to welcome to our program Alexis Vasbinder. Dr. Vasbinder is a PhD in nursing science from the University of Washington out in Seattle here in the United States. And today we want to talk about work that she's been doing on stem cell transplant in relation to cardio-oncology. So she was the first author on a paper on this topic in JACC Cardio-Oncology last year, looking at risk factors after stem cell transplant. But before we jump into that conversation, Lexi, I wonder if you could just tell us a little bit about your background academically and how you developed your interest in cardio-oncology in particular.
Yeah, absolutely. First, I just want to say thank you for having me on this podcast. I'm really looking forward to this discussion on a topic that I'm very passionate about. I am a nurse scientist, so I have, as Dr. Caselli had mentioned, a PhD in nursing science from the University of Washington, and that's where I was first introduced to cardio-oncology. I worked with Dr. Carrie Redding, who's also in the School of Nursing, and Dr. Richard Chang, who's our Director of Cardio-Oncology. During my time as a PhD student, I was really focused on radiation-induced cardiovascular disease and breast cancer. But then I went on to do a postdoc fellowship at the University of Michigan with Dr. Salim Hayek, and I really honed in on cardio-oncology specifically. And there I kind of got introduced to more of the treatment for blood cancer, so looking at bone marrow transplant specifically, and I did quite a bit of work with immune checkpoint inhibitors as well. And then I just recently started as an assistant professor back at the University of Washington in the School of Nursing, but I still am working very closely with Dr. Richard Chang and as a lot of our hematology fellows at Fred Hutch.
Great. Thank you for that background. I'm sorry to hear about the University of Michigan connection. I grew up in Columbus. I'm a diehard Buckeye, so we'll just leave that for now. We'll see how things work out going forward this year on that score. But Arjun, this is an area that I know you have some interest in. What kinds of questions do you have today?
And thanks, Steve. I think it's always quite a challenging area for cardiologists when the hematologists refer us patients for stem cell transplantation. How is the best way to assess them and try and minimize their cardiovascular risk in the short term and then in the longer term? So I think probably it would be helpful maybe just to set the scene if Lexi could just give us an idea about how things have maybe changed in terms of the preconditioning for cancer patients in the space, because presumably that has an influence on the risk that the patients are being exposed to.
Yeah, absolutely. And I think a great introduction to this would be providing just a really brief overview of the transplant process in general to provide some context of this discussion. So hematopoietic stem cell transplant is a curative approach for the treatment of hematologic malignancies, as well as a lot of non-malignant bone marrow disorders. And there are three main phases to this. So it starts with conditioning, where patients are typically given high doses of chemotherapy and or radiation. And this phase really serves multiple purposes. It helps to wipe out the existing bone marrow to create space for the new stem cells. It suppresses the immune system to decrease the risk of rejection. And it also helps eradicate any remaining cancer cells. This phase typically lasts 1 to 2 weeks, but it's a very intense period for patients, and it causes many of the negative side effects we see with giving high doses of chemotherapy. After this, stem cells, either from the patient, referred to as an autologous transplant, or from a donor, referred to as an allogeneic transplant, are then infused back into the patient. And over the next couple of weeks, engraftment occurs where new stem cells grow and produce new blood cells. During this phase, patients are typically very neutropenic and are at high risk of developing infections until these new white blood cells form. Once these stem cells engraft, neutrophils are recovered, then patients will typically move to an outpatient setting and then they enter the survivorship period. But to your question, in terms of conditioning, there are really three main categories, and it's based on their intensity and impact on the patient. There's myeloablative, which is the most intensive, and this is where the goal is to completely wipe out the bone marrow. And this is the type of regimen that has the highest doses of chemotherapy and radiation and really comes with the most severe side effects and prolonged neutropenia. And initial conditioning regimens were really reliant on these myeloablative techniques. But because they were so intense, older patients and those who had a lot of comorbidities were often ineligible for this type of treatment. So this led to the development of reduced intensity conditioning and non-myeloablative techniques that can use lower doses of chemotherapy. And these techniques still lead to immunosuppression, but don't completely wipe out the patient's existing bone marrow. And these newer regimens have really opened the door for older patients to undergo transplant, which has led to this growing eligible population of older adults and those with comorbidities. So while there are a lot of different options now for different conditioning regimens that allow for the minimization of these adverse effects that were from traditionally excluded patients, we are still seeing that a lot of the myeloablative regimens are still widely used, and oftentimes it's necessary depending on the type of cancer and the aggressiveness of it.
Yeah, that's really interesting, and thanks for setting the scene that way. I think that Dan will be asking a little bit about the CARE BMT score a bit later on, but maybe if I ask before that about the traditional cardiovascular risk factors or other risk factors that you would consider before you develop the score into, who's a high risk, who's a low risk patient?
Yeah, so there have been a lot of observational studies looking at risk factors for cardiac complications after transplant. Particularly, these studies were adult survivors of childhood cancers. And the risk factors that were known are many of the traditional risk factors for cardiovascular disease in the general population. These are things like older age, obesity, dyslipidemia, hypertension, diabetes, as well as existing cardiovascular disease. But there are also transplant-specific risk factors, such as the type of transplant, the actual conditioning regimen, as well as the prophylaxis and treatment of transplant-related complications. For instance, allogeneic recipients are at risk of developing graft-versus-host disease, which is often treated with high-dose corticosteroids. And this can actually lead to the development of cardiovascular risk factors after transplant, like hypertension, insulin resistance, and dyslipidemia. And I do want to add, since I mentioned in the last question, that there has been this growing population of patients who are being evaluated for transplant that already have many of these risk factors. So contemporary data were really needed to address these questions. And prior cohorts, which is what a lot of us original data was based on, were often these younger patients and actually excluded those who had pre-existing cardiovascular disease, which isn't necessarily representative of the current patient population. So this is what really drove us to develop our transplant registry to look at this more contemporary data that better accounts for these shifting trends.
Sure. And in terms of what are the big cardiovascular adverse effects that occur acutely and chronically, what would you say that we need to be aware of?
Yeah, that's a great question. I just want to kind of highlight our paper that we published in JACC Cardio-Oncology, which really specifically addressed this very question. As I mentioned, again, these older cohorts were not really representative, so we wanted to create a newer cohort that was a little bit more contemporary. So we created our cohort called the Cardiovascular Registry and Bone Marrow Transplantation, which we've kind of termed CARE BMT to really look at this contemporary incidence. And this is a multi-center registry that included all adult patients who underwent autologous or allogeneic transplant at Michigan Medicine and Rush University between January 2008 and December 2019. Our cohort currently includes about 3,300 patients, and we manually abstracted data from all of these patients. So we pulled out data on their demographics, medical history, their clinical characteristics, their conditioning, prior cancer treatment, as well as all of their cardiovascular events. And we looked at the incidence of cardiovascular complications at various time points, including short term, which we defined as within 100 days after transplant, and long term, which are those that occurred after 100 days. And the overall event rate for these short term events within 100 days was about 4%. And new onset atrial fibrillation and or flutter was by far the most common event, followed by new onset heart failure. But this was actually reassuring to us since AFib flutter is generally pretty easy to manage and not necessarily life-threatening. And even more positive, the rate of severe events like myocardial infarction, stroke, and CVD death were really quite rare. Now, unsurprisingly, the rate of long-term events was much higher, but still the most common events were AFib flutter and heart failure. And even for these severe events, the rate was only about 1% at 5 years. So it's still quite low, which is, again, reassuring.
Great. That's really, really interesting to hear. I think Dan also has a number of questions on this, so I'll maybe hand over to him.
Thanks, Arjun. Yeah, so it's interesting, you can look at cardiovascular risk factors if they've been measured in patients that are undergoing a stem cell transplant. And I think that's probably one of the biggest things is that those risk factors are not ascertained across the board. Now, maybe in a more contemporary transplant registry than, perhaps they have been. But I think that was probably the biggest problem over the years is that, those things weren't really looked at. It was more focus on just the hematologic condition. But one question that always comes, and I think that at least historically, this has been the case. So if you have somebody with heart disease, so the general term heart disease, they are, quote, at risk for cardiovascular problems afterwards. But it's always important to know exactly what heart disease are you talking about. So, for example, coronary disease doesn't appear to be that much of a risk factor for a cardiovascular event after a stem cell. But valvular disease, on the other hand, could be quite substantial. So is that basically what you found, or would you add anything to that general statement?
Yeah, I think it also really depends too on kind of what cardiovascular event you're looking at after transplant. I mean, we kind of broadly grouped a variety of different events together. So we kind of lumped heart failure, AFib flutter, stroke, myocardial infarction, and the risk factors you might also vary depending on the actual event you're looking at. But what we did try to do, and I know you'll probably get to this question in a minute, was to create some sort of standardized way of assessing this pre-transplant cardiovascular risk using some standardized tool that can make it a little bit easier in clinical practice to identify these high-risk patients.
And when you apply, the score that you're going to probably tell us more about, is that something that's readily available? Like, when we talk about some score that we use clinically, it needs to be something that we can kind of get right away. You don't have to go to some textbook and look up a algorithm and then go through the first 10 steps to get to it. So like, Chad's VAS score, you once you understand what it is, you can do it very readily. Do you feel like this score is that way, or do you think it's a step in that direction?
Yeah, absolutely. So we had all of these same goals in mind when we were creating this score. So we used our CareBNT registry to identify first kind of what variables that we had in our registry, and we had collected data on pretty much everything, were most predictive of these post-transplant cardiovascular events. And it ended up being a set of 9 variables. We kind of lumped them into 4 different categories. So there were demographic factors, cancer-related factors, comorbidities, and some lab values. And once we identified these most predictive variables, we then used a point-based system based on estimates from a multivariable model. And this approach was chosen for the exact same reasons you were just talking about. It's a simple and very practical way to calculate in clinical practice rather than having a super complicated formula. And one of the benefits of this score is that it does use conventional variables that are really easily obtainable in clinical practice and can be easily pulled from a patient's chart or collected if it's not. But ultimately, this risk score is just calculated by summing up all of these different points for each factor, and then based on their final score, then they can be assigned as either kind of low, intermediate, or high risk depending on their score. So it really was meant to be something that was easy and quick to do in clinical practice, and it did perform quite well in our patient population. And we also did an external validation in our RUSH cohort, and our findings remained robust. It also worked well for kind of all follow-up periods, so for predicting both short and long-term events. And it did work well when we kind of separated it by allogeneic versus autologous transplant recipients. So it's really a nice tool. I will say it was designed to be a pre-transplant cardiovascular risk score, so it's kind of using these pre-transplant variables, and it's meant to help guide patients to be either referred to cardio-oncology or identify those that might need more frequent monitoring in that peri-transplant phase.
If you or your institution would like to have credentials that confirm your qualifications as a cardio-oncologist or a cardio-oncology center of excellence, we encourage you to consider applying for our certification exam in cardio-oncology or our certification for centers of excellence. These are the only certifications currently available in this field, and it's a special opportunity for you or your institution to distinguish yourself, recognizing your expertise in the field. More information about both these opportunities can be found at ic-os.org, or you can email directoricos@gmail.com for more information.
Yeah, so you kind of mentioned this in the middle of your explanation, but whenever I've tried to get my head around stem cell transplant and the possible manifestations from a cardiovascular point of view, just like again, this is my own opinion. I don't know if anybody else shares this or not, but when you talk about pre-op clearance, and you look at historically in cardiology, you would go from low to moderate to high risk. And those things would be based on the type of surgery. So if you were having some sort of toe surgery, obviously that'd be low, and something like fixing a broken arm or something would be moderate, and then major vascular surgery or something would be high. So you'd have these sort of three general categories for surgery in terms of identifying the risk to the patient. Well, applying that basic principle to stem cell transplant, in my mind, I always put autologous kind of like relatively low risk, allogeneic with a sibling or something like that being sort of moderate risk, and then a matched unrelated donor as your highest risk. And partly because your regimens for preconditioning may be different, or conditioning rather, would be different. And then post-op or post-transplant, their risk for GVH and other things are dramatically different between those. So does your score cover all of those different areas? Does it give us some sort of estimate about, the different transplant regimens?
That's a great question. So the score does take into account broadly allogeneic versus autologous. Again, for those same reasons, we did see that allogeneic recipients are at a much higher risk of cardiovascular complications for a lot of the same reasons, like developing graft versus host disease. It didn't break it down so much in terms of the donor type, and that's partly because in our cohort, we didn't have a lot of representation across the board to really get very clear estimates of that. So it didn't come out in our variable selection. techniques that we used when we were looking at the variables that were most predictive of CV events. So we really tried to take kind of all of the variables that we've had in our data set and limit it to just a subset that were going to be the most predictive, because we didn't want to have a score with 20 plus variables. So we were really trying to cut it down and determine the number of variables that was going to give us the best performance.
Super. And so after doing all this intensive analysis of this, what I would consider a very large data set, what do you think the weaknesses, or what do we need to improve on to make this even a more useful tool?
Yeah, I think there are a number of different areas that can be further investigated. Regarding this tool in general, we are looking to do further validation of the risk score. So we've been actively growing our CareBMT cohort to include additional sites. And we've started collaborations with people from University of Chicago, University of Minnesota, University of Kansas, and MD Anderson. So this will hopefully not only grow our cohort to be able to look at other clinical questions, but we'll also be able to continue to update the patient population over time to account for changes in transplant practices in general. And as I mentioned, the CareBMT risk score is a pre-transplant risk stratification tool, but there's certainly a need to develop more cardiac specific tools for the survivorship phase. And there's been some scores that have done this in the past. But again, they were from these kind of older cohorts, younger populations who were free of cardiovascular disease. So this is really an area that should be revisited to take into account all of these shifting trends. And that is an area we're actively pursuing in our CareBMT cohort. And we're continuing to collect post-transplant data on these patients. And we're collecting data on factors like graft-versus-host disease, its prophylaxis and treatment, as well as the development and change in cardiovascular risk factors throughout the survivorship phase. One particular area that we've been actively investigating is the impact of post-transplant cyclophosphamide. So this has been a growing area of interest since it's being used more and more for the treatment and prophylaxis of GVHD. But there's really been very little longitudinal data on the long-term cardiovascular risks and how to best care for these patients. And then just another area that I'm really passionate about in general is working on developing and implementing a rehabilitation exercise protocol for these higher risk patients so that we have something to hopefully do about it. And the goal is really to improve cardiorespiratory fitness before somebody undergoes transplant. So hopefully the heart is better able to tolerate the process. And this is definitely some work we've been doing at the University of Michigan. And we are looking to conduct some larger multi-center studies in this space to see if it can actually reduce cardiovascular events in the peri-transplant phase. And in general, there's been a lot of push for these types of cardio-oncology rehab type programs, but ultimately they haven't really come to fruition in many places. So there's really much more research that needs to be done to determine how to best implement this in clinical practice.
Super. Those are really good answers. Arjun, what do you think? How do you see this applying to your practice?
Yeah, I think this is a question that we were actually discussing during ESC. Steve, I think, mentioned that we were at ESC recently and talking to other cardio-oncology colleagues, talking about scores. And we have, of course, the HFA, ESC, ICOS risk scoring algorithms. And this is all kind of part of that whole kind of risk assessment process. So I think similar to the point that you made, Dan, about is there an easy way to kind of access this? And, the web-based interface is obviously a nice tool to make it simple to use, simple to access. And I think that probably when we do talk about, a general cardiologist or a general hematologist, something easily available and usable is always going to be the key to get in. And I think probably a question for Lexi would be, what she's found in terms of implementation, and have you been told from different centers that we're using it, or what's the feedback been?
So far, I'd say the feedback has been quite positive. So this is something that we've been working on implementing actually at Michigan Medicine, where I was doing my postdoc and getting it into Epic. And we've also been told actually from collaborators overseas in Europe that they've actually been implementing this in clinical practice, and they're kind of looking at whether or not this is impacting patient outcomes. And we're hoping to actually submit a grant to look at the clinical implementation of a score and whether or not it does improve outcomes and the best way to implement this. So these are all great points and questions that we are looking to answer hopefully pretty soon.
I think that's a point that we raised as well with for example, the HFA ICOS scores about how does it work in clinical practice. And even this time at ESC, there were a number of studies, including one from my group about, the clinical utilization and in real life, how does it work? So I think probably that's definitely the next step to see how it performs in practice. And I think the point you raised about integration into Epic or Cerner is obviously makes it easier. So I think Dan probably that's one of the rate limiting steps to implement in a lot of places, the electronic health record interface.
Yeah, so Lexi, I guess another point is, you're a member of a task force for the AHA or American Heart Association scientific statement. And how do you think this information could relate to that, and how important do you feel that it might be from a clinical practice point of view?
Yeah, great questions. This was a really exciting statement to work on because it was actually the first guideline statement of its kind to really highlight the cardiovascular management of patients undergoing transplant. And a lot of our data, our papers, really provided key contemporary data to guide a lot of this information. And the statement in general, it really nicely lays out the role of cardio-oncology specialists throughout the entire transplant process. So it does talk about the pre-transplant evaluation, which includes this initial risk stratification using a tool like CareBMT. But it also really walks through and provides guidance on the inpatient peri-transplant phase and what to expect during transplant. So, thinking about the need to look at fluid shifts, like monitoring weights, fluid intake output, as well as arrhythmia management, which is quite common in that peri-transplant phase. And then it summarizes nicely to the key points in the survivorship phase, highlighting the need to really monitor and optimize long-term cardiovascular risk. So really focusing on diet, exercise, having a healthy lifestyle, managing blood pressure, lipids, etc. So this is really the first guideline statement on this topic. It really covers many important areas, but there's still a lot of room for further research to help refine this risk stratification process, as well as thinking about evidence-based strategies to optimize cardiovascular outcomes in these patients. And one particular area too, and this seems to be a common theme throughout all of cardio-oncology, is really thinking about how frequently would we be doing cardiovascular monitoring and for what groups of patients. So this is where scores like the CareBMT or another score can really help in identifying these highest risk patients. But we still don't really know the best screening and surveillance intervals that are really optimizing care.
Wow, Lexi, this has been really tremendous, and we appreciate all your efforts. And certainly we look to see about now, is this statement that you're referring to, has that been published or is it in process?
It has been published in circulation this past year. Okay,
great. We'll have to make sure we take a good look at that. But thank you so much. And Arjun, what do you think about what you heard today? Is this something that really is going to help you manage, your patients that are about to undergo a transplant?
Yeah, I think absolutely. And I have to say, this has been one of the best podcasts that we've had. I would say it's been a really clear and succinct kind of explanations from Lexi to, our listeners, I think, in terms of, taking us all the way from, the pre-transplant assessment and how things have evolved from autologous, allogeneic, and then what the different risk factors are. And I think that the statement that she was involved with from the AHA is quite comprehensive and quite useful. I mean, there's been some earlier statements which probably I would say are out of date, and this is much more contemporary and very useful. And I think really comes to the heart of what we need in cardio-oncology, which is more evidence-based care And I think it's only through these studies and statements that we can, slowly progress towards that goal. So, real, kudos to her and with the team at AHA for producing that document.
Lexi, thanks so much for your time today. We really appreciate it. Thanks for sharing your expertise with our community, and we will look forward to catching up with you in the future and following your research going forward.
Thank you so much for having me today, and these were very thought-provoking questions, and I really enjoyed our conversation.
For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.